Welcome, everybody, and happy AERD Awareness Day. My name is Eddie from the Samter Society, and it's an honor to host the day's live webinar where our world's leading experts in AERD are here to answer your questions that you've submitted over the past few months. So please join me in giving a warm welcome to our distinguished panelists, Dr. John Bosso, Dr. Elina Jerschow, Dr. Tanya Laidlaw, and Dr. Andrew White. We'll begin with a few intros and then we'll dive into the questions. So, Dr. Bosso, why don't we start with you?
Sure, age before beauty, right? Uh, yeah, this is my 36th year in practice. Trained at Scripps Clinic, where, Drew Wright is right now. And that's kind of the origins of where AERD research started. Um, so that's where I got my interest. I was in private practice for over 25 years, started a local AERD center in the Hudson Valley area of New York, and then was recruited to Penn Medicine, University of Pennsylvania, about 10 years ago. We have a multidisciplinary AERD center, and that means that I work with sinus surgeons closely, and in the same confines. And so, we like to believe we give more seamless uh, care where we're communicating about cases on a regular basis, and this is yeah, and in real time. Um, I'm clinical professor at the University of Pennsylvania School of Medicine, so I do teaching and of course research as well as seeing patients. And happy to be here and share some of our expertise with the audience. I think it's a great way to educate our patients and also to get them more interested in their condition. And I don't think there's anything better than that because my more educated patients always seem to do better.
All right. Thanks, Dr. Basso. Why don't we go next to Dr. Jerschow?
Hi, everyone. My name is Elina Jerschow. I started my ARD journey in 2009, just when I returned from pharmaceutical company back to academia. And that's where actually my first IRB was dated April 2009. So since then, I have been very passionate about this condition, most of all because it's so puzzling and also because I feel blessed with the patient population that I can provide care to. So I feel very fortunate that many of you are coming to us, and we hope to help you somehow. So when I was in New York, Bronx, New York, our team built a probably most ethnically diverse cohort of patients with ARD. And this cohort gave a lot of questions and navigation throughout the field. And so I learned a lot from my patients there. But 3 years ago, I changed my job and I came to Mayo Clinic in Rochester, Minnesota. And now I'm the chair of the division here. But my most important task so is to continue ARD research, awareness, clinical care, and practice. So with my new research team, we continue researching, and our primary interest is in polyp tissue because we find it very puzzling how polyps do affect the state of health overall. And we're in particular are interested in immune cells and how they interact with the polyp tissue in general, and what do they do to make us feel better or worse. So that's my area of research interest, and thank you all for joining. So I'm happy to try to answer some questions if you have.
Thank you. Thank you. Next, we'll go to Dr. Laidlaw.
Sure. So I'm Tanya Laidlaw, and I'm at the Brigham and Women's Hospital in Boston at Harvard Medical School. And I actually came to AERD as an area of interest through a rather strange place. I actually am a pediatrician originally, and I think I blame that as the reason I landed here because when I came to train in fellowship in allergy and immunology, I had come from pediatrics background and I had never heard of AERD or Samberstride. I had never seen a patient with it because it's largely an adult disease. And so as we were talking, in my fellowship about, what my area of interest might be, I started asking questions about it. And I was constantly frustrated by the lack of answer, right? So why is it that, these patients develop this in adulthood, having been totally healthy kids? And the answer is, well, we don't know. Well, why is it that aspirin causes these strange reactions? Well, we don't really know. Well, what happens actually when you can desensitize them to aspirin for some of the patients? Like, what's the immunologic change? We don't know. Well, how come it is that for some patients, high doses of aspirin actually make them better? Like, well, we don't know that either. And I don't think I would have had the guts to ask those questions if I had been an adult doctor where I was supposed to know some of the answers, but I felt okay not knowing them. And I started asking so many questions at the end that our division chief, my boss, sort of looked at me and was like, "Why don't you go find out?" So here I am now, 20 years later, trying to still find out. I am frustrated that I haven't found out as much as I would like to about the disease. I think at the end of the day, what I really want to know is what causes it from the immunologic sort of mechanism side, so that we can then figure out how to potentially prevent it, but at the very least, treat it better and cure it. Um, but it's been a great joy of mine to meet patients with this syndrome. And I really have to say that it's been a wonderful way to feel as though what we do in science and medicine has really mattered because I think we've made a lot of pretty good progress, at least on the patient side for treatments in the last decade. And it's been nice to be part of that. So thanks.
Thank you. Definitely true for a lot of us here. Dr. White.
Yeah, thanks everyone for coming. It's great. It's actually cool. I'm sitting here controlling the webinar, and I keep allowing more people in. It's great to see how many people are interested. So looking forward to today. So I go by Drew White. I'm an adult allergist, and I also kind of fell into this by accident. I didn't really even know I wanted to go into allergy, and I sort of picked it as the least offensive specialty of everything I could think of as I was finishing medicine. And I came to Scripps and didn't really know that Scripps had a real significant interest in AERD research. And so the physician I connected most with in my training was Dr. Stevenson. He became my mentor, and before I knew it, I had this really keen interest in AERD and trying to understand it. And a big part of our training, as Dr. Bosso will remember, is going to the bedside during the desensitizations and really thinking a lot about what's happening with these with you all as you're going through the desensitization. So that's sort of where I started. And then after some time, Dr. Stevenson retired, and I was able to take over a lot of what he was doing here. So that was kind of my story. I've been interested recently from a research standpoint in, how do we, with all the different tools we have now to treat AERD, how do those modify some of the aspirin reactivity? So, maybe we'll talk about that a little bit later today, but with the different biologics and some of the medicines we've had over the years, we know that sometimes people won't have as significant of a reactivity when they take aspirin, either by accident or during a desensitization. So that's what we've been thinking about. And to close out, I think I think Dr. Laidlaw once told me that once she figures out AERD, she would retire. So
Yeah, I'll stick to that. Absolutely. Yep.
Okay, thanks, Dr. White. So why don't we jump into the questions? I know Dr. Bosso is really excited to answer this one. So these questions come from Lori M, Liz H, Maddie S, and Laura N. So the question is, what are the long-term risks and benefits of daily aspirin therapy for AERD, particularly in older patients?
Yeah, so my anxiousness comes from the fact that we just completed and just had accepted for publication in the Annals of Allergy, a paper where we looked at 278 patients and we looked at the reasons for their aspirin intolerance. So these are patients who were treated with aspirin after they were desensitized. It's a large cohort, and they were followed for in the area of 2 to 3 years, which is a long time. We excluded people who didn't have at least 1 year of follow-up. And so when we looked at the reasons for discontinuation, out of the 278 patients, I have the numbers in front of me, 17% of patients that was the discontinuation rate. 48 out of 278. 23 of those patients, or 8.2%, had GI complications. So that was the leading problem, and I think no one's surprised by that. 7 had anaphylaxis, which is 2.5%. 5 had lower airway symptom worsening. That's 1.8%. Skin reactions, 4 patients, 1.4%. Multiple reasons, 4 patients, 1.4%. 3 patients had upper airway symptom worsening, 1.1%. And 2 patients, or 0.7%, were unable to be desensitized. So that's over 80%, 83% of patients did tolerate aspirin. So then we took a deeper dive to see if there are any ratios based on demographics that could potentially say, well, is there a certain group that tolerates this better? And so we looked at male versus female, premenopausal versus postmenopausal, and we found that postmenopausal and perimenopausal women had actually a decreased risk of intolerance. In other words, they were more tolerant of aspirin than other females and males. Building on what Dr. Jerschow had a few patients that she reported on a number of years ago, Hispanic and Latino patients and African American patients had a much higher incidence of intolerance, and that was statistically significant. Age did not seem to make a dramatic difference. It was a slight difference. It was 1.08, so like 8% higher. So a very modest change with age, not as much as one would expect, because the thought is that you become more intolerant with age, but really that didn't bear out to be too dramatic. And dose did not seem to make a difference at all. So those were kind of the findings of taking a good deep dive at intolerance in a large population of patients who were able to follow for an average of about two years, some people up to 3 years. And so that kind of answers the question, well, what are the risks? And are they worse in older patients? And the answer is only slightly in older patients. And in terms of the benefits, well, I think the rest of the group will answer those questions for you, since I've taken up my minute and a quarter, I think, already, unless you want me to do that. But I think we have, Eddie, I think you wanted to have everybody answer on this one.
Yeah, why don't we go next to Dr. Laidlaw?
Well, I did want to bring up one last thing about that data, which is, and we don't have this published yet, but it is going to be submitted for publication. That 17% discontinuation rate is the same discontinuation rate that we have for 104 AERD patients treated with dupilumab. And that's not published yet, and that has not been accepted, but we have pretty good stats on that as well. All right. I'll let everybody else talk about the benefits and anything else related.
Eddie, do you want me to go next?
Yeah, please go ahead.
Sure. So I 100% agree with everything that John has suggested. I think it's great data, and those are really hard studies to do to get enough patients with enough good data to really understand what it means for the larger group. On sort of an individual patient basis, I have to say that I'm overall, over the last 20 years, have been pleasantly surprised at how safe high-dose aspirin has been in the long term for our patients. You'll often get the primary care doctors who are terrified that you put your patients on multiple aspirins a day, and yet really our patients do remarkably well. And one of the nice things about aspirin is that we've known about it for 127 years or so. And so we really do have extraordinarily long follow-up data for patients on aspirin. That's really encouraging in that sense. So we're not worried about some new strange long-term side effect coming up that we hadn't heard of before, which is helpful. In terms of when it's the most beneficial, it is, I think, largely to prevent polyps or delay polyps from coming back. And so in the sort of classic textbook case, it means that patients will go to, and get a good, thorough sinus surgery to remove all those inflamed polyps. And then when you're feeling great after surgery, but before they start to come back, you initiate the aspirin desensitization for daily aspirin. And that there's a high chance that it will at least delay, if not totally prevent, those polyps from growing back for as long as you're on it. And if anyone wants to ask, why we think that is, please don't, because the answer is we honestly have absolutely no idea immunologically why it works, and we've tried to figure it out, and it's hard to figure out. But I have been a little bit like Dr. Bosso suggested, very pleasantly surprised at how safe it is for most patients.
Okay, thanks, Dr. Laidlaw. Dr. White, mind chiming in?
Yeah, I'll keep it quick. This is sort of the data that replicates with more patients what we had a long time ago at Scripps, which was about the same, actually. About 15% of patients would have some sort of side effect or problem and would end up stopping. And so it's nice that it's been so consistent, that we're seeing that kind of the same numbers. And same experience. I mean, at Scripps, we actually created a letter that the patient would go home with explaining why we're doing high dose aspirin so that they could show it to their referring or primary care doctors to help them understand why we're doing it, and that it does seem to be generally very well tolerated.
Okay, great. Your thoughts, Dr. Jerschow?
Everything that has been said really resonates well with me. I think that's absolutely correct. I'll just add to Dr. Laidlaw's statement about the pill that we have for the past 127 years. If we look back into the history, we probably have it for the past 2,500 years in form of a plant medicine, right? Because aspirin effects have been described first by Hippocrates 2,500 years ago. And then eventually Hoffman and synthesized the pill in Switzerland at the end of 19th century. So basically, we know this plant medicine for quite a while. And one thing I really like about it is also something that I've seen in several studies, especially from Europe, where they have accessed the data from the healthcare system, where they have a lot of access to prescription data. And they compared the effects of aspirin to other NSAIDs, such as ibuprofen, naproxen, Voltaren in Europe as well. And they found that actually the only medicine that was with cancer preventative associations was aspirin. So people who took aspirin for 20 years or longer, they had a reduction in incidence of specifically GI cancer, and it kind of goes from bottom to the top. So from the rectal to colon to stomach to esophageal cancer prevention, but also breast for women, prostate for men, did not affect lung cancer or brain cancer, but nevertheless, it had like this strong anti-cancer association. Obviously, because it's cross-sectional data, they couldn't know for sure what's the cause and what's the consequence, but the fact that it was associated makes me reassured.
Okay, well, that's interesting. All right, great. Thank you for that. Let's go to our next question, and this comes from Vivian M, Laura N, and Michelle K. And we'll try to keep these short, hopefully to a minute or so. So we'll start with Dr. White on this, and we'll go through the panel. What is your preferred gold standard treatment for AERD when cost is not a factor? Or is therapy best tailored to individual patient factors such as nasal polyps?
Well, I would say best tailored to the patient. I think it's hard to say, there's going to be like this one size fits all approach. The great thing is that we have so many different tools right now. And you all know that, when you show up at your doctor's office, like not everyone's just coming in on their very first visit, very first time getting diagnosed with AERD. Patients have been, on a journey. They have had surgery in the past sometimes. And so I think the gold standard is really like, what specifically is the biggest problem for the patient? Is it sense of smell? Is it the need for surgery? Is it postnasal drip? Is it asthma? Is it the need for aspirin? And then we focus our treatment based on that. So I would, at least in my practice, I wouldn't say that there's a default gold standard.
Okay. Dr. Laidlaw. What do you think?
I'm going to cheat and say the exact same thing that he said because I agree entirely. I think it's very patient specific in terms of things that you are more or less worried about in terms of the symptoms that bother you, and or more or less worried about in terms of side effects of medications or what kinds of medications, needle phobic versus not wanting to take a pill every day. There's sort of pros and cons to each one. I would say if I were to pick a totally generic gold standard for every patient, all things equal, it would probably be one very thorough sinus surgery with a trusted surgeon, followed by aspirin desensitization and initiation of aspirin, and then figuring out if that is helpful for you and safe for you. If it is, awesome. We stay on that as long as we can, for as long as it works. And if it is either causes a side effect or isn't helpful for you in terms of being therapeutically efficacious, then we would give up on the aspirin and move to biologic.
Okay, thank you. Dr. Bosso.
Yeah, I mean, there is no gold standard, and unfortunately, cost is always a factor. But I agree with Drew and with Tanya. It is very individualistic. I mean, if you have a patient who has severe uncontrolled asthma up front, you may be considering a biologic earlier. If it's mostly upper airway disease, that's the problem. You may be considering surgery in most patients up front earlier. And so, the surgery, as Tanya said, should be with someone who has advanced training in sinus surgery or does a lot of sinus surgery. And topical steroids really need to be a mainstay once you've had surgery, because what you're trying to do is you're trying to deliver medication to the mucosa, to the lining of the sinuses, once you've taken out all the diseased tissue. So then aspirin desensitization or a biologic is usually necessary because most patients are not managed just with topical steroids alone, although some are. So there's still a percentage of patients that need neither aspirin nor a biologic, but the majority end up needing one or the other. And again, comorbidities, social determinants, insurance coverage, patient problems they may have. They have a pre-existing condition that may, prevent them from being on a certain therapy. So, this is not, again, not one size fits all.
Okay. And lastly, Dr. Jerschow.
Yeah, totally agreed. So I learned one thing from Dr. Laidlaw one day. We discussed surgeons. I think good surgery is so important. And I was complaining about how sometimes people feel offended if we refer our patients to rhinologists rather than a local ENT. And I remember Dr. Laidlaw saying that she has it in her mind, saying, Tanya, do the right thing. And now I'm doing the same thing. I'm like, Elina, do the right thing. So I refer my patients to very trusted surgeons. And I think having a good surgery before starting any adjuvant therapy would be super important.
Okay, thank you. All right, for the next question, this will be directed to Dr. Jerschow. And this comes from Donna W., Lori M., and Liz H. And the question is, do AERD symptoms improve or even go into remission with age? And if so, what mechanisms might explain this?
Got it. Thank you. So I don't know if it ever goes into remission. I had challenges on my patients in the cohort who were 90 years old and 87 years old. And they knew about their disease, but because part of the study, they kindly agreed to undergo the challenge. And we had positive challenge. Yet, that being said, my oldest patient in the cohort is now 94. And when I ask her how she's feeling now, she says a lot better than in my 40s. So, and that's not the only patient. So that's just one example. But I've heard this from others as well, that when the disease just starts, it's really very aggressive. And I think the body needs to adjust to it somehow. But once it does the adjustment, it actually becomes milder. And while disease duration and the age are obviously correlated, because the longer we live, the longer we probably have the disease. Yet it's not always the case when the disease starts late in life. So, for example, if I have a patient who started with ARD at the age of 70, at the age of 74, she was as miserable as if she would have been if she was in her 20s or 30s, meaning the disease was very, very aggressive. So the duration of the disease is almost like paramount importance compared to the age. And if the duration and age are going hand in hand, then obviously as older we get, the better we get. That's my experience. Obviously, unfortunately, I don't have much data to support my observation, but that's my clinical experience.
Okay. All right. Thank you. All right. So for this next question, we'll go to Dr. Laidlaw. And this question comes from Hannah I and Trish P. How do hormonal changes such as pregnancy, menstruation, perimenopause, and menopause influence the onset and severity of AERD?
Good. So I can cheat because the conclusion at the very end is going to be we're not entirely sure. But in terms of some more detail and evidence and data that's gone into this, so there is actually a slight female predominance in ARD. It's somewhere around 60% of ARD patients are female and 40% are male. We don't know why that is or whether or not specific hormones play a role there, but that has been known for a long time. We also see that women tend to, on average, develop ARD a little bit younger than men. So in our cohort of about 2,500 patients, when we ask when their polyps first started, that's sort of like the date or the age at which we think the syndrome actually started. For women, it's about 33 years old on average, and for men, it's more like 37 or 38 years old. So, not extreme. We have lots of men in their 20s and women in their 70s, but on average, it's a little younger for women. And then also, although it's luckily rare, ARD can actually develop in childhood, in adolescence. And there too, it's a little bit more common in girls than in boys. And I follow a couple handful of adolescents, teenagers with ARD, and I have yet to see any patient where I'm fully convinced that the entire syndrome developed before puberty. So not that young. Whether or not the hormonal changes during puberty are related or not, we aren't sure, but we haven't seen it really in very, very young prepubescent children. And then once you have the disease, like sort of what are the effects of menstrual cycles and menopause? In women with ARD, perimenstrual worsening of asthma symptoms and of sinus symptoms is relatively common, although it's not clear that it's actually more common for patients with ARD as opposed to patients who have asthma and sinus disease otherwise, because perimenstrual worsening of asthma is not uncommon in other asthma patients as well. And what Dr. Jerschow mentioned, we do tend to see a sort of fade out of the severity of the disease over decades. So that in your 80s, it tends to be a little bit less severe than your 70s and vice versa. Though to her point, that might have more to do with how long you've had it than your exact age. I have not seen a clear worsening post-menopause in women. So I think in general, that isn't something that we see overall. In terms of the role of pregnancy, there it's the same rule of thirds we were always taught about asthma, which is that folks who have asthma and AERD and who become pregnant, about a third of the patients actually find that their respiratory symptoms are better magically during pregnancy. About a third of patients have slightly worse symptoms and need more medication, and about a third stay the same, and we don't know how to predict that. One of the hard things about pregnancy with AERD is that aspirin being one of our mainstays of treatment is not something that you can stay on for your entire pregnancy. So that often becomes difficult. We need to stop the medication and restart it post-pregnancy.
All right. Thank you for that. All right. So I think our next question will go to the panel. And I think we covered the first part about the importance of surgery before any treatment. But let's go ahead and talk about.
Are you skipping one?
I think I may have renumbered it.
Oh, okay.
Yeah. And the question is, when are surgeries such as polypectomy truly necessary for ARD patients, and how do outcomes compare to preferred treatment method without surgery? And if we could focus on the outcomes and perhaps, how important is it? And we'll go to Dr. Bosso first.
So it's extremely important because I would say that 90+% of patients will require a surgery. Many of them have it way before they see us. The key is surgery is not surgery is not surgery. We talked about this already. Having an advanced sinus surgeon who can really do a complete surgery, open up, get rid of all the bony partitions, widen the openings into the sinuses, make it so the purpose of surgery is so that you can have topical therapy reach the lining of the sinuses, the mucosa. And so if you have a crappy surgery, you're not going to be able to get medicine where you need to get it, and it's going to be not very effective. So we've come up with a index called the Completeness of Surgery Index. And we hope that this starts being, or COSI, COSI. We hope this starts being used throughout the surgical community, because what we found is if the COSI is greater than 70, then you probably won't benefit from additional surgery. But if your COSI is under 70, then you probably will benefit from more surgery. So it really does give some quantitation to surgery, which is something that has never been done. It's always been, well, this person had surgery, and how do you know whose surgery is better? And we've learned that the more advanced surgeons, the rhinologists, probably do it better. Oh, not probably, they definitely do it better. They have more training. They do that all day, and that's their main thing. So of course they're going to get better at it, and they do a more complete surgery. But that now that we finally have this completeness of surgery index, I think that's going to be used more and more. It'll be something be very easy to do, very easy to implement in the clinic. And I think it'll eventually have like an AI tool that will be able to look at a CT scan post-operatively. I mean, most surgeons will get scans post-operatively, and this is a post-op scan that you can look at to see whether or not surgery was adequate. But if surgery is not adequate, everything else is going to fail. Your topical therapy has no chance. It's like an asthmatic who's not using an inhaler correctly, and it's not getting deep down into the airways. If the medicine doesn't get where it needs to get topically, then it's not going to be effective. And then how can you say that your whole treatment is ineffective? Your surgery is not good. It really, really does come down to how it's done. So we're trying to get a better handle on quantitating this.
Okay. Dr. Jerschow, your thoughts?
About surgery?
Yeah. How did the outcomes compare to having sinus surgery and not having sinus surgery? And then, like, building upon what Dr. Bosso said, are you able to tell when a surgery is not successful and kind of
Sure.
correlate that to your patients?
I think John summarized it really well. So I agree with his approach, and I did have a few patients who actually did well on aspirin before surgery. Like some of them were almost miraculous responders, but unfortunately that effect doesn't last for too long because then exacerbations came back, and the sinus, especially the sinus exacerbations, were quite severe, meaning requiring antibiotics and prednisone. Now, I do have to say that I'm still puzzled by the Polish data, which has been published quite extensively. There is another group like Scripps, I think, and Polish group in Krakow. They started probably around the same time on ARD research. And so they report on patients who actually undergo aspirin desensitization without surgery, or surgery was like way before, sometimes 10 years or 5 years before aspirin, and yet patients respond really well to that treatment. I don't see it so often here in our population. So I don't know what's special about Krakow group, but that's their experience. And I spoke to the investigators, and they just say that they don't necessarily require surgery to benefit from aspirin. Maybe there is something different about the patient population.
Okay. Dr. White, any comments on that?
From surgery standpoint, what I was actually going to just say are that both Dr. Laidlaw and Dr. Jerschow did separate studies showing this really interesting effect that the aspirin reactivity will actually diminish in patients after they have their polyps removed. And I think it's interesting from a couple perspectives, but it speaks to this intensity of inflammation that you have in your sinuses, and actually removing that seems to have this effect on the disease in general, which is super interesting, and also speaks to, I think, the importance of removing it, right? So it's a different take on it, but that's what I was going to say.
Okay. Dr. Laidlaw?
I'm not going to add anything. That's super thorough. I agree with all of the above.
All right. All right. For the next question, this will be a multiple choice. So there's no wrong answer. And the question is, what is the long-term safety and effectiveness of budesonide rinses and or soaks? And the options are very safe, safe, more research is needed, or consider alternatives. Why don't we start with you, Dr. Laidlaw?
I'm going to say very safe.
Okay. Dr. Bosso?
I'm going to say very safe, but I don't know that soaks have been as well studied as rinses. So I think for the rinses, very safe. For the soaks, probably very safe.
Okay. Dr. White?
Yeah, I'm going to go with very safe.
Okay. Dr. Jerschow?
I'm sorry. I I would like to say very safe, but I really want to define first what is safe. Because when I think about the bone health in women after using budesonide for decades, I'm not sure if I feel so safe about it, given the fact that when I see patients who religiously take budesonide, I also see a lot of systemic changes, meaning I am suspicious that budesonide may also contribute to some systemic effects, much more than, let's say, nasal sprays. That being said, for the first year, I think it's mandatory. For the rest of it, I would say more research is needed. For the first
Okay.
year,
But
first.
add one thing there that we've been using the last few years, we've been using almost exclusively mometasone. And I think, the studies show that there's less systemic absorption, and we believe it's a safer steroid. And I think that, we'll need long-term data to back that up, but I think we're pretty comfortable with mometasone with less systemic absorption and less than 0.1% systemic absorption. I think we feel pretty comfortable that up to 4 milligrams a day has been shown in the literature to be pretty safe.
Okay. Yeah. Definitely interested in more in here, but hear more about that. Let's see. Our next question comes from Sia B, Antoinette B, Kelly P, and Carla D. And we'll have uh, Dr. Basso field this question. What conditions are most commonly associated with AERD? Um, and what does this reveal about the underlying immune dysfunction?
So we know that chronic urticaria is found, or at least a chronic urticaria-like condition is found in about 2 or 3% of our AERD patients, and that's an autoimmune condition. I actually have one of my allergy fellows has been combing the literature, and she's almost ready to publish findings from the Penn database looking at autoimmune disease incidence in AERD and in patients who have CRS, chronic rhinosinusitis with nasal polyps, but don't have AERD. And what her preliminary data looks like, there's a much higher incidence of lupus, rheumatoid arthritis, and sarcoidosis in patients who have both polyps and AERD. And there were no difference between polyps and AERD in terms of the incidence. So they both were much higher than the general population and also the general Penn population. So again, this is not published yet, but we're seeing this, and I think the other docs will agree with me that if you take good history, you'll find there's a lot of our patients have RA, SLE, sarcoidosis. They've had it in the past. They're more than you would actually see in a general allergy clinic. So there's something about polyps and AERD. The thought is maybe it's just polyps alone. I mean, there are studies showing that there are autoantibodies that are found in these polyps, and so I've always thought that polyps and AERD are are autoimmune diseases that we haven't figured out what the autoantibodies are and what the mechanisms are. Of course, we don't have the data for that yet. We just think of it as a dysfunctional immune process. But I really do think that if I'm around long enough, I would really like to take it to the next step, which would be to start looking in the lab for autoantibodies specific for AERD, and if not me, whoever else is still doing this kind of research, because I do think that there is some, there's a lot of similarities to autoimmune diseases amongst these conditions with the AERD and polyps. So these are unanswered questions at this point, but certainly intriguing.
Okay. And talking about research, I'd like to remind everybody that our shirts that we are selling this year, 100% of the proceeds do go to research, and they will go directly to our research centers that are led by these wonderful doctors. So if you haven't done so already, please go ahead and buy those shirts, and or feel free to donate directly to each center. We have a link on our website if you want to do that. And for this next question, this will go to Dr. White. This is a question from Candace N. What is the true incidence of AERD among asthmatics, and does prevalence vary across populations or environments?
Yeah, I love that question. That was something about 10 years ago or so we tried to figure out. The short answer is it's, maybe like 8 or 9% or to round up to 10% of asthma patients. The problem is that, as you know, this is a problem, this is a disease of the sinuses and polyps. And so if you look at an asthma population, that's not, maybe not quite the exact population. It hasn't been as well studied in just everyone who walks in the door with polyps, but probably also around 10%. But where we really care are the patients that have both polyps and asthma, because that's tends to be the important components of AERD. And so in that group, it might be as high as 30%, a third. So those are sort of the main numbers, like around 10% of polyps or asthma, around a quarter to maybe 30% of people that have both asthma and polyps. And then the other things that we can look at, which I think will help us a little bit, are looking at some of the studies. If you look at the biologic studies for polyps, those studies have patients with asthma in them. Not everyone had to have asthma, but these are patients that have had difficult to control polyps, and then they're eligible to be in a study. And so for all of those studies, it's around 20 to 30% of the group reported having AERD. So I think that's kind of a good ballpark if you're trying to say what's the percentage chance. And I would actually bet that if you asked someone who doesn't really specialize or care as much about it, how common it is, the other doctors would probably think it's much lower than that. So, it's much more common than we would generally appreciate. In terms of the kind of global population, or if there are places where we don't see AERD, there was a study a while ago now, maybe 10 or 15 years ago, from China. They looked at a big group of patients that had polyps, and they only found it AERD in 2%, way lower than we would have expected. And there's some interesting reasons why, at least at that time, 10 or 15 years ago in China, the type of inflammation in the polyps also was a little different. And so that might be the one exception, but it doesn't seem to be a whole lot different, at least in ways we can measure in other parts of the world.
Okay, thank you. All right, so this is the question I've been most excited to hear about. And this comes from Ashley B, Max V, and KCC. So what are the most promising new areas of AERD research? And some of the examples given were AI tools, NMT, new biologic, and what unanswered questions should future studies address? And we'll start with Dr. Laidlaw.
Oh, great. I think I'd probably divide my answer into two parts. One is looking for newer, better treatments to improve just sort of symptoms and control of disease and patient comfort, with the goal of getting to something that we can use for a period of time and then stop, and the disease doesn't come back. So rather than just being a treatment, it's a cure. I do think that we've had a lot of success with the biologics in the last decade. That's been super helpful for many patients, but they're not perfect. And none of them thus far are cures. And I think we should aim for that for sure, in part because, as Drew says, once I figure that out, I can retire. So that'd be great. The second part of that, which is related, is the using the laboratory science to really understand what's causing this inflammation at the base. And as sort of nerdy and like lab sciencey as that sounds, I don't think we have any chance of discovering or developing or creating new treatments if we don't know exactly what it is that we're treating. And so I think the continued push at the lab to collect samples, to figure out what are the components within the polyp tissue, within the blood, within the nasal fluid, within the lungs that are driven to kind of be abnormal in this condition so that we can then figure out how to renormalize them it is going to have to be something that we continue to push forward with in order to then, and this is a slow process, which is super frustrating, in order to then figure out how to target them to change them back to normal. So the end goal is going to be treatments that last so long, they're essentially cures. But I think to get there, the most promising sort of areas are the ongoing immunology of the disease.
All right. Dr. Jerschow, what exciting research are you working on?
So totally subscribe under everything that Dr. Laidlaw just said. So I think aiming for cures is really our goal. Because right now we have symptomatic control, which seems to be working for many patients, hopefully for most of the patients. So I would like to say for all, but probably not for all. But cure is really the goal. That's number one. Number two, like Dr. White just alluded to, we don't really know how many people are affected by the disease. And one of the reasons why we don't know is because there is no diagnostic test. So people who don't have access to performing aspirin challenges, which by the way, by themselves sound very medieval to me. When people come to my office and say, hey, I don't know what I have to tell them, please come back and I'll make you feel worse. So that's really frustrating because it's frightening to have an asthma attack. And even though I know many of you went through a lot, yet when the asthma attack happens, it really makes us completely paralyzed. And sometimes I see so much fear in the eyes of my patients who undergo the challenge. So I feel extremely guilty for not having a better tool. So finding a place where we could do a lab test and say, you have certainty of so many percent to have ARD, you don't have to go through the challenge, would already save so many people from undergoing this procedure, and also will make it more available to those who don't live close by to a center that performs the challenges, because many patients don't even have access. And when we have access by itself, aspirin challenge, not only asthma attacks, but I think Dr. White and Dr. Bosso, they published on pancreatitis caused by aspirin challenge. And we see it in our clinics as well, people who have GI responses, that's very difficult. So I think cure and diagnostic test would be my aspirations. So I guess then I'll also retire.
All right. Dr. White, tell us about some of the research you hope to discover and look into.
I have 4 kids, so I can't retire anytime soon. So I think it's really cool. I think we all are kind of hitting on some different research interests that we think are important. I think one that is something I would love to see is some sort of a test that helps us predict the therapy that works for the patient. You know, we all can recognize that we can follow a patient over time, and a lot of times we'll get the patient to the point where they're satisfied, they're controlled, they're happy, we're happy. But sometimes it takes like 2 or 3 tries with different therapies before you get there, and it might take a year. And it would just be so nice if we had some testing. And I think that may be where AI comes into this, where, you know, there's like actually a big cluster of data and lab testing and things that we have access to, and it all can kind of get dumped in together and then spit out that, you know, these are features that makes us think this patient actually might do better with aspirin therapy, and this patient might do better with a biologic. So I think that's probably the one thing that I feels like is a glaring miss right now in how we approach the patients, and I'd love to see from a research standpoint in the near future.
All right, great. Dr. Bosso, go ahead.
I agree with A, B, and C. Everybody brought up some great thoughts. The ability to predict who responds to what, having biomarkers, having better testing, having something that eventually shuts off the disease, knowing if there are any abnormal predisposing factors. And really, what bottom line is, if I'd like to see us be able to prevent this disease. I mean, globally, the long-term effect is not just to treat it, and obviously we'd like to have a cure. But wouldn't it be nice if, we started with prevention, just like they started with heart disease, back with the Framingham study, years and years ago when they started looking at risk factors and ways to prevent this from developing. I think that's what I'd like to see more emphasis on, because, the morbidity in this disease is significant. And if we can prevent patients from actually developing it, I think that would be really that would be the holy grail, in my opinion.
Okay, great. Well, we're all excited for it. We do have about 6 minutes left. So why don't we go for one more question? And this comes from Michelle T. And it's beyond medication, what holistic or functional approaches, such as diet, mucolytics, or lifestyle changes, can support AERD symptom management? And we'll start with Dr. Laidlaw.
Sure. I mean, we've talked a lot about the sort of dietary control that we studied a few years back with high omega-3 fatty acids, but more importantly, low omega-6 fatty acids in order to try to overall reduce those levels of the inflammatory lipids that we call leukotrienes and prostaglandins. And I still think there's efficacy to that, and it's certainly helpful for patients. It can be a really tough diet to follow, so it's really not for everyone. And it tends to be hard to keep your calories up. So if you're a thinner person, it's even harder. In addition to that, I think there are something not necessarily well-published studies that I'm aware of, but sort of like a gestalt we get from our patients. There are a couple of things that we've noticed for sure. Reactions to alcohol are relatively common. And so we have lots of patients where decreasing or cutting out alcohol from their diet is helpful in terms of decreasing generalized kind of respiratory reactions overall. And one thing that I'm actually curious for the other panelists if they've heard this before, but I've had a number of patients tell me that when they exercise intensely, and usually it's either cycling or intense swimming, hiking, running, that they feel dramatically better during their period of intense cardiovascular exercise. And I've heard it now from enough patients that I'm reasonably sure that's true. And I have a rule of threes I tell my patients. If I have one person tell me this, it's some new weird thing, I'll blow it off and ignore it. If I have two people tell me the same thing, I'll remember the first person. And if I have three people tell me the same thing, now I have to go back and actually study it. So I believe this is a real thing. The reason it confuses me so much is because asthma is often worsened during exercise. And we think that's actually because exercise-induced asthma increases more leukotrienes when you exercise. And our patients with AERD already make too many leukotrienes and make more when they get reactions to aspirin. So I cannot put those two things together, but I'm sure my patients are right. But immunologically, I don't understand what could be happening to make that better. I'm seeing lots of thumbs up. So it sounds like other patients have also had this experience, which is great. We should all be hiking, biking, running, swimming more. But I'm curious, have the other panelists heard this as well? And do you guys have any better theories than I do about what's going on with that?
I can just say that holistically, I mean, what I've noticed is patients who eat better, who take care of themselves better, who exercise more, who have just a healthier lifestyle, seem to do better than those who just kind of let it go, and we don't have a great study to back that up. I think we need to, sometimes it's hard to put that all together in one package, but it kind of says everything you just said, which is, yeah, maybe not someone who, does exercising once in a blue moon, but, someone who makes it a regular habit and someone who may not necessarily have to follow the omega-6 diet. Maybe they're just following the Mediterranean diet or just overall just watching their calories, not overdoing it on inflammatory foods, just in general, having a more healthy lifestyle. And I think, we don't have hard data on that, but it makes perfect sense. And I've certainly seen it anecdotally in the clinic that patients who are more health minded. Now, does that mean that those patients maybe that are more health minded, maybe they're more likely to take their medications regularly, and maybe that's why they're doing better? I mean, I don't know. I mean, definitely think it's an area for us to look into.
All right, Dr. Jerschow, what are your thoughts?
Agreed. Healthy lifestyle never hurts. I think there are some patients that are really very much health minded, but I also would like to acknowledge some challenges that not everybody has the opportunity. Coming from Bronx, New York, I can tell you that living above bus depots sometimes is not a choice, but it's a basically given necessity. And when my patients tell me every morning I open up my windows, I smell the exhaust of the bus, the yellow bus that drives kids to school and kind of outdated in New York area. I think they really don't do well also because of the environmental pollution. And so I think decreasing that piece would be also very helpful. And some studies actually do support that, although I think we don't need to create a hypothesis that fresh air is good. But there was a study, I think in the 90s, where people were with asthma were put in Swiss Alps, and after a month, they all felt better. So I think that's just like for every one of us would really do some good things. Yeah.
All right, Dr. White, why don't you close it out?
I actually haven't heard that, Tanya. That's really cool. I mean, I agree with the like general healthy lifestyle as being good, but this sort of specific high intensity exercise. So it was actually super exciting to see people putting their thumbs up. We got like a case series here out of this. Yeah, you guys may actually see a survey coming out from Dr. Laidlaw's cohort.
Good idea.
Yeah, and then we can sort of try to guess at why that might actually be true. So.
Okay. All right. Well, I'd like to thank each and every one of you for joining us. And on behalf of the Samter Society, thank you. Why don't we give everybody a round of applause to our wonderful doctors and researchers that are helping us in our everyday lives. And thanks again, and happy AERD Awareness Day.
Thank you, everyone.
Thank you, Eddie, for
Thank you, Eddie,
too, and for the other Samter Society folks. It's really appreciated.
You guys were great.
Thank you, everyone. It was really a pleasure.
Thank you.